Holiday and welcome to Medicine Grand Rounds. I'm David Guido. I'm the Division Director of Pulmonary, Allergy, Critical Care, and Sleep Medicine. And I'm delighted to have sleep, one of our four disciplines, represented at Grand Rounds today. We have a panel discussion that reflects the multidisciplinarity of sleep medicine. And to lead it off, I'd like to introduce Dr. Nancy Collop. Dr. Collop is Professor of Medicine and Director of the Emory Sleep Center, and one of the prominent academic pulmonologists and sleep specialists here at Emory, and she'll be kicking us off. Nancy?
Great, thank you, David. I'm just going to take a minute and introduce my colleagues this morning. Dave Schulman is a professor also in Dr. Guido's Division of Pulmonary Critical Care, Sleep and Allergy, and also the Program Director for the Pulmonary Critical Care Fellowship. Dr. Sheri Katz is joining us this morning. She's a dentist in private practice whose dental practice does oral appliances for sleep apnea, and she's an expert in the field. And Graeme Mulholland is one of our sleep fellows this year. He's an ENT specialist who is also training in sleep medicine and works with Dr. Raj Dadia, who's our ENT specialist in the Emory Sleep Center, and he's going to be talking a little bit about surgery and sleep apnea. So I'd like to start with a case of a patient I saw about a month ago. He's a 40-year-old white male who was originally studied in Florida, told he had sleep apnea. He was given a PAP machine. He didn't know if he had a BiPAP or a CPAP. He actually never saw anyone after he got his PAP machine, which is not uncommon. We see this quite often in the center. He didn't really like the way the machine was set up, so he went on YouTube and fixed the pressure himself to what he thought was comfortable. We also see that quite often. Since his study was about 5 years ago, he said he gained about 25 pounds, and his wife noted that he was snoring when he had his machine on. He didn't bring his sleep study or his PAP machine with him on the day of the visit. But when asked about how often he uses it, he says he rarely misses it because if he misses it, he'll develop a very sore throat, and even one time had to go to the emergency room because his uvula swelled so much after one night of sleep. And in addition to wanting to have his PAP machine checked out, he's also interested in if there were any alternatives to PAP therapy. He says he sleeps about 7 hours most nights, wakes about 4 or 5 times a night. He says when he wakes up, even with using his machine, he's not that refreshed. He drinks about 6 cups of coffee a day. He also has some chronic nasal congestion. He hasn't got any new supplies for his PAP machine in over 3 years. And his Epworth Sleepiness Scale score is 13 out of 24. He really is pretty healthy. He only had been told he had hypertension a few times. He termed it pre-hypertension. But he does have a family history for coronary disease in his mother. She's currently 65, but she had coronary disease in her 50s. He doesn't really smoke, drinks a little bit of alcohol. He works for a national staffing agency. So at the visit, when I saw him, his blood pressure was a little bit high, 135/92. His SAT awake was 96%. His BMI was 34.6. His heart and lung exam was unremarkable. He'd have very crowded airway with a high tongue base, lateral narrowing of the pharyngeal walls, and 1+ tonsils. His neck size was 18 inches, which would be considered at risk for sleep apnea, and he had some mild micrognathia. So I'm posing to our panel members what should be the next steps in the diagnosis and management of this particular patient. This is a very typical patient we would see in the sleep center. One, does he need another sleep study? Should his CPAP, does it need adjusting? And if it does need adjusting, what should the pressure be set at? And why is he still snoring with his CPAP mask on? And then to get to his question, well, what else is there out there if I don't want to use PAP therapy anymore? What about dental appliances, or are there surgical alternatives for this patient? And I'm going to task our panelists with helping answer some of those questions today. So obstructive sleep apnea, of course, is repetitive collapse of the upper airway, either partial or complete collapse while the patient's asleep. It's a highly prevalent disorder, and it's estimated in adults between the ages of 30 and 70 that 6% of females and 13% of males will have at least moderate sleep apnea. If you use a lower threshold and say they're apnea-hypopnea index, which is the number of disordered breathing events per hour of sleep, is more than 5, and they have excessive daytime sleepiness. It's about 5% of women and about 14% of men. So very prevalent. It's much more common in men than women in general, but once women go through menopause, the prevalence of sleep apnea is about the same. So menopause is really a big risk for females. Sleep apnea has a number of consequences. We know it's associated with a number of cardiovascular diseases, metabolic diseases. Patients will have neurocognitive deficits. They'll suffer from more depression and mood disorders. Their quality of life is reduced. The excessive daytime sleepiness can lead to motor vehicle accidents and difficulty in home, school, and work. Patients that have obstructive sleep apnea are at increased risk for high blood pressure, heart disease, heart attack specifically. Stroke is one of the most common outcomes of a patient with obstructive sleep apnea with regards to cardiovascular disease. And cardiac arrhythmias, high prevalence of atrial fibrillation, and even sudden death. It can worsen heart failure and diabetes. And the risk for sleep apnea with some of these is more probably tied to the amount of oxygen desaturation, resaturation, rather than that AHI number that we use to define severity. And the risk of death actually goes down a little bit after the age of 65, so it's a much stronger risk for cardiovascular disease in the middle age years. If you're not diagnosing obstructive sleep apnea in your patients, you probably should be, because it's highly prevalent in patients seen in internal medicine clinics. Diabetes, it's estimated, one study said 82% of patients that come to a diabetic clinic have obstructive sleep apnea. As I mentioned, if you go into hospitals, into stroke units, you'll find a very high prevalence of sleep apnea in those patients. Probably a third of patients with heart failure have obstructive sleep apnea. If you add on central sleep apnea, if it's even higher diagnosis, even higher prevalence. If you go into cardiology units and patients with acute coronary syndromes, about 2/3 of those patients will have sleep apnea. Therapy-resistant atrial fibrillation, almost all of those patients should be studied for sleep apnea. And the same with poorly controlled hypertension, particularly in males. The prevalence of sleep apnea is incredibly high. I'm going to switch and talk just for a second before I get to my other panel members about diagnostic testing for sleep apnea. The Emory Sleep Center really was established as a center around 2011. And the yellow bars there represent the number of in-lab sleep studies we've done. And you can see it's been relatively stable. The difference between 2012 and 2013 was we went from 6 bedrooms to 8 bedrooms. We moved to the Emory Sleep Center to Executive Park in around 2015. And the amount of in-lab studies has actually remained relatively stable. But what you'll see in the blue bars is the home sleep apnea testing. So you can see that we've had an incredible increase in home sleep apnea testing over the years. And I suspect this year we'll probably do as many home sleep apnea tests as we do lab tests. The preferred name really is home sleep apnea test instead of home sleep test, because most of these tests don't actually measure sleep. So you're really screening for disordered breathing events. And they're a rule-in test. It's not a good test to rule out sleep apnea. It's more a positive test is good likelihood that the patient will have sleep apnea. You don't typically want to do it in patients that have comorbid conditions. We just don't know the sensitivity and specificity in those conditions, like heart failure, anybody that's on oxygen or has significant COPD, anybody who you think may be hypoventilating, or of course anybody that can't follow instructions or keep the device on. It shouldn't be used for anything other than obstructive sleep apnea. So you don't want to use it for hypersomnia disorders, including narcolepsy, insomnia, because we're not really measuring sleep, unless you think it's specifically from sleep apnea, restless legs, periodic limb movements, or even parasomnias. It's not what the test is for. It's to diagnose obstructive sleep apnea. It does have a little bit higher failure rate than polysomnography, although we've gotten pretty good at it, and our failure rate now is actually less than 5% last time I checked, so it's a very low failure rate. You can get false negatives. So again, if you have a patient that has a home sleep apnea test and it's a negative test, then oftentimes you have to go to the lab test. And now most insurance companies are requiring this test first. even if it's not necessarily appropriate. Sometimes we have to argue. That doesn't include Medicare. Medicare, you can still do both, but most of the private payers are pushing towards the home sleep apnea test. The two devices we use, I'm going to go over real quick. We use a device called a WatchPat. It's a little device that sits on your wrist. It has a cover over your index finger, and then this is a little sensor here that sits on the sternum and measures body position and snoring. It has a unique signal using peripheral arterial tone that mirrors changes in the autonomic nervous system. And it uses that signal plus heart rate variability and oxygen saturation to identify breathing problems. Also integrates that snore signal. It even gives an estimate of wake, non-REM, and REM sleep based on activity and heart rate variability. So this is what the raw data looks at. We don't typically look at the raw data because it's an automatic scoring algorithm that just spits out the data to us, but this is what it looks like. This is the ANS signal, this is the sum of it, and these are the oxygen desaturations that are occurring with the patient, and it's tagging these events based on that scoring algorithm. This is kind of the meat of the report. So this guy has obviously very bad sleep apnea. There's so many events, they all just like a single block. This is snoring, the yellow bars. You can see that's measured in decibels. The black line represents body position. This is oxygen saturation. You can see he's pretty bad. This is heart rate variability. And this is the estimate of sleep that it gives. So it's kind of a very cool device. And then we get recording time, and it actually gives you what it suspects is the valid sleep time based on those signals. You get an AHI and an RDI. The difference is pretty minuscule. It just has to do with the amount of oxygen desaturation that occurs and a minimum SAT, and then we even get information on position. The other device we'll use is a more standard device that looks at airflow and effort. It's the Embleta MPR. This is what it looks like. This is what a patient looks like wearing it. You can see there's a little airflow signal and then 2 effort belts. The box itself is here wrapped around the patient, and it also measures body position, and then there's an oximeter. So you get more of the standard signals that we see in a sleep study with snoring based off that airflow signal, thoracic and abdominal effort, the sum, and then the oxygen saturation. So here the patient's having obstructive apneas, and over here some obstructive hypopneas. It also gives you a respiratory event index, the difference being it doesn't have a surrogate for sleep, so it's all based on total recording time. So maybe a little bit less accurate, but it also gives you information about the oxygen saturation. So to finish up my section, we were able to get his sleep study from Florida. It was done about 5 years ago. He's gained a little bit more than 25 pounds. His BMI at the time was 24. He had a respiratory disturbance index. Again, that's the total number of breathing events divided by the sleep time of 11.7, but he did desaturate to as low as 63%. And then he also had a CPAP titration, which only lasted for 78 minutes, part of the same study, and his CPAP was set at a pressure of 7. So we're going to let Dr. Schulman come up. He's going to talk to us a little bit about CPAP and how it can be used both diagnostically and therapeutically. David?
Good afternoon, everybody. So thanks for the invitation to be part of the panel. It's an august group. I'm going to spend a little time talking about the principles of CPAP, in particular what's relevant to most of us, which is how do we actually get patients to use it. Not an insignificant number of folks will come back after CPAP has been provided to them, and they're not doing well. They're struggling. They're residually sleepy. And so the 3 questions I will always ask when a patient comes back having been prescribed CPAP is, are they using it? If they are using it, is there something wrong with it that is in providing insufficient therapy? Or potentially they're using it and it's doing the right thing for the patient, but there's some concomitant comorbidity that would explain why they're sleepy. So these are the 3 things I want to talk about. Adherence, of course, is the biggest problem. Estimates of adherence vary widely in multiple studies, from 30% to 70%. Nobody has a pill for sleep apnea. If you want to make $1 billion discovery, find a pill that works for sleep apnea. They've tried respiratory stimulants. That doesn't work. There's a new study on cannabinoids, which is kind of a junk study, but all the marijuana proponents really like that study, but there's not much there. We really don't have a great pill for this. So as of now, CPAP is the gold standard therapy, but adherence rates are really problematic. We define adherence as using therapy for at least 4 hours a night, at least 5 nights a week. That's really a suboptimal definition. The insurance companies utilize it to sort of judge whether folks are on treatment regularly, so they'll continue to pay for therapy. There are some data which would suggest that probably 6 hours on a reliable basis is what people need to be normal. Now, you'll start to see benefits with as little as 2 or 3 hours a night, but if you really want to target normalcy, 6 hours should be the goal. There are a lot of reasons that folks don't adhere to CPAP therapy. Those that relate to the patient, they just may not understand why it's important for them to use it. They may not understand that this is not only going to provide them potential healthcare benefit, but also subjective benefit on a day-to-day basis. Social support's important. They need coaches. And while we as providers can be really good coaches for them, other folks in the house, particularly those who might complain about snoring, can often be an additional impetus for patients to utilize therapy on a regular basis. And then we don't often think about it, but there are physical limitations. Putting on a CPAP mask is not an insignificant task. It's not the most terribly complicated thing in the world. But if there are visual issues that limit the ability of the patient to push buttons on the machine, or some hand coordination issues that prevent them from putting the mask on and strapping it on, that could be a barrier. There are problems with the therapy itself, and I'll spend a little bit of time digging a little deeper into these over the next few slides, but people can struggle with adverse reactions. They may have some cutaneous reaction to the mask. Leak can be problematic. It can cause, if the leak goes in the wrong direction, it can cause some corneal abrasions and problems there. There is not an insignificant expense. All of the therapies we're going to talk about today do cost something to the patient, and I've become a little bit more sophisticated over the last 5 or 10 years as to exactly what the financial costs for these therapies for the patients are, and I try to disclose that on intake just so they're not surprised, but that can be a barrier for some people. And then some people after a day or two will get frustrated and say, well, it's not working, and they'll stop, when easy troubleshooting, if they came back to see us, could fix those problems. And clearly there are things that we can do also to better educate our patients and to try to be on a team with them, to be supporting them, understanding, disclosing them up front. Hey, look, this is going to be a hard therapy for you to use, but if you can climb the mountain, the view from the top is going to be fantastic. So trying to develop a good patient relationship and helping them understand that you understand this is not simple, and struggling with it is not saying anything bad about you. Let's keep working together. The first 2 weeks of therapy are critical, and there are studies that show that seeing a sleep specialist prior to provision of CPAP therapy actually improves longitudinal adherence, because we can kind of help them understand what to expect from treatment. So the first 2 weeks of adherence predict longitudinal adherence. And some basic things that we can do just on intake: mask fitting, making sure they're on a mask that's comfortable, that fits them well. Heated humidification, in the majority of patients, provides a slight benefit. So having them have a humidifier in the device, almost all of them come with a built-in humidifier now, but also that's heated, that increases the humidity of the air being inspired, can help. And then trying to mitigate air leaks. There are 3 things in particular I want to do a little bit of a deeper dive in, and this is useful, I think, for anybody who's going to be either providing CPAP or managing patients who are on CPAP therapy. And as Dr. Collop said, this is a highly prevalent disorder, so this is a fairly commonly prescribed therapy. So the first is mask choice. There are 3 common types of mask interface. There are nasal masks that go over the nose, nasal pillows or prongs that go under the nose, almost like a large oxygen cannula, and then oronasal masks that go over the nose and mouth. The chief challenges with nasal masks, either over the nose or under the nose, are mouth leak, right? The oropharynx and the nasopharynx are connected in the back. Most patients know that. Hopefully most doctors know that. But if you put air in the mouth or in the nose, and the mouth isn't reliably closed, which can be hard to do, particularly when the patient's asleep, you can get mouth leak. And that's going to cause dryness in the mouth. It can cause sleep fragmentation. It can cause noise that's bothersome to the patient's bed partner. And so it can fragment sleep. So that's a potential issue with nasal masks. They can add a chin strap. So you say, well, I'm going to give you a nasal mask, and then I'm going to give you a little bit of a chin strap that's going to just be a snug, not blood-curdlingly tight, but just a gentle reminder, don't open your mouth overnight. That can help to mitigate leak, but now you're putting more stuff on the face, and there aren't a lot of reliable data showing that makes a difference. So why not try to cover them both? Why not go with an oronasal mask that's going to cover both the nose and the mouth? Well, now you've got more stuff on the patient's face, so there can be some claustrophobia issues. There's also a theoretical worsening of upper airway obstruction, because if you're putting pressure on the lower part of the mandible, you're going to push that mandible posteriorly. That posteriorly pushed mandible can narrow the airway behind it and therefore increase obstruction and will cause higher pressures. So this is a nice study that was done just earlier. It was published just earlier this year, looking at all 3 types of interface. I'm going to talk about nasal masks and NM, nasal mask with a chin strap, which is NMCS, and then oronasal mask. And the beauty of the study is they basically divided the volunteers into 6 subgroups, and each of the 6 subgroups got all 3 therapies, but in a different order. So everybody served as their own control. So the number of subjects in each arm is fairly small. You're not seeing any more than 10 subjects in each arm and as few as 5 in one particular arm. You can see that a fairly modest number of people completed the study, only 4 in some arms and 8 in others. But a total of 35 subjects were analyzed in this 6-arm study where everyone served as their own control. And what they found basically, and I'll ask you basically to focus on the p-value here, is that the significant differences between nasal mask with a chin strap, and then oronasal mask are going to be found in terms of how much leak there was, with an oronasal mask surprisingly have a significantly higher leak in minutes than the other two. Even though mouth leak would be concerning for these two arms, the total leak was much higher in the oronasal mask arm. Overall satisfaction was much higher with the nasal mask than with the oronasal mask. That's on a 1 through 10 visual analog scale. Residual disease, AHI, which the machine measures, I'll show that in a little bit, was actually a little bit lower with the nasal mask than the oronasal mask. And then how many people had significant residual disease with more than 10 events per hour? Much greater percentage with people with the oronasal mask. So in sum, on almost every metric, the nasal mask wins. These oronasal masks that theoretically would decrease oral leak are, I don't want to say reliably worse because I'm sure there are occasional patients for whom they'll do better, but in general should not be used as first-line therapy unless there's a compelling reason to do so. Well, what else can we do? We have new fancy auto-adjusting machines, right? Back in the day, we only had a fixed pressure. We had to set that machine to a fixed pressure, send the patient home with it. But now machines are smarter, and they can adjust to the patient. They can sense obstruction, and they can vary the amount of pressure they provide depending on what they see the patient doing. So that would be better, right? So this is a study that tried to answer that, also published earlier this year. So it basically compared 2 different arms of patients, one on a fixed pressure of CPAP, one who was put on an auto-titrating device and stayed on it long term. We used to use it for a week and then convert them over, but this is long term. So let's take a look at, is one therapy better than the other in terms of how it provides benefit to the patient? So 2 arms, about 100 subjects in each arm, fixed CPAP here on the left of the slide, auto CPAP on the right. You can see that the majority, getting down to 80 on the left, 92 on the right, remained in the study through the end, and the majority of those were adherent to therapy on a reliable basis. So there's a per protocol analysis and an intent to treat analysis. I'm going to show you the upshot of the study. Fixed CPAP on the left, auto CPAP on the right. You'll notice very few statistically significant differences. This is in terms of how sleepy they are, how objectively prone they are to sleeping. This is basically a sleep latency test where you bring them into the lab and you measure how sleepy they are. This is another subjective outcome of sleep. This is how much better they got functionally. No real difference here. The only statistically significant differences were, not surprisingly, the auto CPAP provided on average a lower pressure because the device will adjust up and adjust down throughout the night. So when the patient's in a non-supine position, they'll require lower pressure, and therefore the average will be a bit lower. And there actually was a statistically significant difference in terms of adherence, but actually the adherence was better with fixed pressure, not with adherence. Now that's only a 0.2 hour difference, so a 12-minute difference on average is probably not a clinically relevant difference, but it's not entirely clear that this matters one way or the other. So this is not going to help a lot. Nasal mask, good. Fixed versus auto doesn't matter. The third thing that we can do now is we can actually help the patient see how they're doing. People love data. People love scores, right? Everyone wants to know how they're doing on anything. So what if we could give the patient a score whenever they use CPAP? Well, we can do it now. The new devices allow patients to self-monitor adherence. The device itself might show it, or they can go online and pull out their phone and bleep bloop with their Bluetooth and see what's going on with it. So is that going to do better? Here's kind of what it looks like. Right? This is one particular brand. I think this is the ResMed model. No brand favorites. This is just the picture I chose. And the patient gets a score. I got an 85 today. That's good. Everyone loves the score. And it breaks down the score into how much they use therapy, how well the mask fit, how much residual disease they had. So everyone loves numbers. So what I'm going to show you here, this is a retrospective analysis. That's going to be a problem, as I'll get to at the end. This is a retrospective analysis of a group of patients who got feedback, APE is active patient engagement, versus no feedback, usual care. And what you can see, at least in this one retrospective study, at least in this one retrospective study, you can see that people who got the active patient engagement reliably did better. They were more adherent when you looked at all comers. On the bottom row, people who struggled at 2 weeks, not that 20% is great, but 20% of people who were struggling at 2 weeks doing great by 90 days is pretty good. Much better there in the active patient engagement group and the usual care group. Earlier adherence and more hours per night. So there is something to this getting a score. Patients love to get feedback, and it looks like that feedback maps to better use. So there are a number of things that we can do to get patients on board early. We can sell them on the device early, let them know what they're getting, let them know what we can expect, let them know that it's trouble. It can take some getting used to. Favor a nasal mask, and give them something that will give them feedback. Okay? Now here's another chart of those data. Okay? So in sum, this is great. Now the challenge of this study is it wasn't randomized. So it's retrospective. Is it conceivable that providers tended to give patients who would have done better anyway the active patient engagement, the score? It's possible. Maybe people who were randomized or who were non-randomized, who got the active patient engagement, didn't actually look at it. So we're actually not sure that that stimulus is what caused the outcome in question. That said, the machines are fairly similar in terms of cost, so I think it's become standard of care to give folks this feedback now. All right. So that's ways to get the patient adherent. If the patient is adherent, what else could the problem be? Well, maybe the therapy is not sufficient. We heard from Dr. Collop that this patient in particular was making some modifications to the device. We saw on their initial CPAP titration, they only got to a level that yielded them a residual respiratory disturbance index of 7 events per hour. Well, that's not normal. It's not bad, but it's not normal. But even a mild amount of residual disease can cause sleepiness. So maybe that's the problem. This guy did not have an adequate titration in the lab. He's not using an auto-titrating machine at home, so he has residual disease. Even folks who have an adequate titration in the lab often sleep deeper at home. They may have a different body position. They may be more comfortable and therefore get a deeper sleep. They may tend to sleep on their back more at home. They may have a little alcohol, which can tend to exacerbate sleep apnea. So there are many reasons that sleep can be deeper at home and therefore lead to worsened disease in lab titration, not yielding adequate control. There also is some degree of night-to-night variability. And the last thing to think about is there's something else going on. There are comorbidities, not surprisingly, that cause you to have sleepiness and fatigue. Narcolepsy, although it's a rare diagnosis, is more common in people with sleep apnea. If you don't think about it, you'll miss it. There are a lot of drugs that we all use that can cause fatigue, and so we do want to think about those sorts of things. We don't want to always, while the sleep problem is easy to blame, we want to think about potential other contributors there. So back to our patient, Dr. Collop said, well, we're going to look at some of the data. We can use CPAP diagnostically. So this is actually a download of the patient ES's CPAP. And what you're looking at here is a 90-day view of his utilization of therapy. Each line is a day. The height of the line tells me the number of hours of use on that day. If the line is green, which the majority are, it means the patient is getting more than 4 hours a night. If the line is red, which occasionally it is, it's getting less than 4 hours a night. Now you may say, well, Dave, how do you know the patient isn't just turning the machine on and letting it go and fooling you? Well, if the machine's not seeing any adherence, the line turns black. So this person is reliably using therapy for, it looks like an average of close to about 6 hours a night. And in fact, we have another table that validates that. So this is a tabular representation of what I just showed you. And if I go to here, average usage and days used, you can see he's actually averaging 7 hours a night on each day. So that's pretty darn good. The machine also measures some other salient variables. So could large leak be an issue? We measure large leak basically as the amount of leak it would take for the machine to be unable to provide a therapeutic pressure to the patient. It's only 12 minutes a night. So even if we subtract that out, he's still getting more than 6 3/4 hours a night of therapeutic use. So that's not it. What about residual disease? His average AHI is 6.0. Again, our target is less than 5. So he has some mild residual disease. Now, not everyone with mild residual disease is going to have symptoms, but some of them will be. So particularly in the context of snoring, until further notice, this is kind of where I'm hanging my hat. And so when I look at this differential diagnosis for the residually sleepy patient, for patient ES, I would argue that the therapy is probably not sufficient. This is the problem. And so my recommendation, which may differ from my esteemed colleagues with a patient like this, is I want to assess how willing he is to stay on CPAP. He's not gotten the full benefit of CPAP. So if he's frustrated with the therapy, I get it, because he's using it and he's not seeing the benefit. But what if I can say, look, ES, if I can make some tweaks to this treatment, I might make you feel better. And he's already got the therapy. It's easy to keep in hand. Let me bump the pressure a little bit. Let me convert him over to one of these auto-titrating modes, which might also control his disease without being a big change in what he's doing. Now, we will hear about some alternates, but my advocacy in this case, probably just from a standpoint of what's easy for the patient, would be to take the device he's on, tweak it slightly, get him on board the team, and see if we can get him to win. All right. I've said my piece. Dr. Katz, I will turn it over to you, and let's see if you can sell them on oral appliance therapy in lieu of the best treatment there is. Floor is yours.
Thank you, David. Well, I will start by just acknowledging that CPAP is the gold standard, and we like our patients on CPAP when they can tolerate CPAP. Oral appliances work by keeping the airway patent at night, and the way it does it is that most of the muscles of the airway are connected either directly or indirectly to the mandible. So the cephalometric X-ray on your left is showing the person with his teeth maximally closed together, and because all the muscles are attached to the mandible, you can see the tongue and soft palate spilling into the airway space. On the right, the person has his mandible protruded, and it's carrying along the tongue and soft palate, and you can see how it's dragged the tongue and soft palate out of the airway. And it's a little more complicated than this, but essentially oral appliance therapy makes the muscles more competent by keeping the mandible forward slightly and keep it from going into free fall. So these are examples of oral appliances. They're custom made, and this is what it looks like intraorally. The elastics keep the mouth up, and this mechanism, and there's many different types of mechanisms that dentists choose according to the patient's presenting anatomy. The mechanisms keep the jaw in the forward position. The way of choosing whether to use oral appliances for your patients is outlined pretty nicely in a practice guideline that was last published in 2015. They come out every 10 years, and it's based on 51 randomized control trials. And because most of the randomized control trials are comparing oral appliances to CPAP, because it is an option of treatment compared to our gold standard of CPAP. So we know that CPAP used greater than 6 hours decreases sleepiness, improves function, and improves memory. And it's based, as Dr. Schulman had said, on this chart showing that the y-axis shows the percentage of normal values versus the amount of time the patient's using it. If they're using it 2 to 4 hours, you're seeing a lot of improvement, and the improvement continues to approach normal values up to about 7 hours. So that chart is what our definition of adherence or compliance is based on, and adherence is based on using oral appliance therapy more than 4 hours of night. But having said that, it's thought that between 46 and 83% of our patients are not using CPAP. So what are we going to do? And I want to talk to you about oral appliances being used as an alternative. In those 51 papers, we've compared oral appliances to CPAP in use, comparing how it does with snoring, reduction of the apnea-hypopnea index, improvement of the oxygen desaturation, and how it performs in improving sleepiness, quality of life, and blood pressure. So we know that oral appliance therapy can be very effective in the management of snoring, and snoring is defined as a diagnosis based on the absence of obstructive sleep apnea, not just patient report. And when we're talking about just snoring, it's considered a first-line treatment. Patients like it better, and patients' bed partners are thought to choose this as a first line too. However, CPAP is superior to oral appliances at reducing the apnea-hypopnea index and improving oxygen saturation. And I have all of the data here. If we're looking at the no impact line here, oral appliances don't do as well as CPAP in reducing the apnea-hypopnea index or improving oxygenation. These charts are showing pre-treatment versus post-treatment patients with oral appliances. And with custom titratable oral appliances, we do have a positive impact. So if you have patients that are coming to you that are unable to use their CPAP for more than 4 hours a night, you do have a good option. Oral appliances do a fine job in general of reducing reducing the AHI and improving oxygen. So how about sleepiness? That's what most of our patients are coming to us for. They're in trouble while they're driving. A lot of them are falling asleep at the wheel. They're having problems coping at work, staying on task. They're having difficulty with relationships with families. That's why they're seeking medical care. They're tired. So how are oral appliances doing? Well, we are doing just as well as oral appliances when compared to CPAP at improving sleepiness. And we're also doing just as well compared to CPAP and improvement of quality of life. And the studies are showing this based on the short form quality of life study form, and it asks questions about how someone feels about himself in relationship to his family and friends, how a person performs activities related to helping others, how one performs in personal development creativity, and how a person perform socially. It's about how they're living their lives. And we are doing just as well with oral appliances and CPAP. You can see they're running neck and neck here in how they're working. We're also doing just as well at reducing diastolic and systolic blood pressure. And to show you that, that oral appliances versus no oral appliances is showing an improvement in systolic blood pressure as well as diastolic blood pressure. And when we compare it to the effect that oral appliances have versus CPAP in improving blood pressure, you can see we're really doing the same thing. We're improving their blood pressure here. So how is it that oral appliances are doing just as well and improving quality of life, sleepiness, and improving blood pressure? And we feel it's because that patients are more compliant than CPAP. So let me show you how that is so. Before I show you that, I want to show you that we do have compliance chips. It's not as detailed as the data you're going to get back from a CPAP machine, but it does, it will chart how much the patient's using it. So, and here's the data for adherence. What I want to show you is why oral appliance therapy should really be in your toolbox here. And it's through a concept called mean disease alleviation. If we have a patient with very severe sleep apnea, an apnea-hypopnea index of 50, and we give them a CPAP, and they're using it half the night, 4 out of 8 hours, they're thought to be 50% compliant. If the AHI reduces their the severity of their sleep apnea to a 5, their efficacy is thought to be 90%. It's put them almost to a normal range. So their mean disease alleviation, how much it's supporting their health in general with CPAP, is thought to be 50% compliance times 90% therapeutic efficacy equals a 45% mean disease alleviation. So let's give that same patient an oral appliance. And this patient is using the device 3/4 of the night, 75% compliance. The AHI is reduced to 10, which is still mild sleep apnea, but now we've taken them away from the severe category to a mild sleep apnea, and it gets them out of the cardiovascular risk category for the most part. The mean disease alleviation for this patient is 75% compliance times the therapeutic efficacy of 80%, and it gives them a mean disease alleviation of 60%. So if that same patient was using their CPAP all night, of course you'd want them to be using their CPAP. But if they're only using it half the night, they're doing a better job using oral appliance therapy. And to further illustrate this, let's do a hypnogram of a night's sleep from midnight to 7 o'clock, and they have a series of 1.5-hour cycles, and then this is basically what humans look like. The first half of the night has more slow wave sleep, more deep sleep, and very little REM sleep, which is represented by the red. And the second half of the night, they have a lot of REM sleep and almost no deep sleep. And we know that REM obstructive sleep apnea is associated with hypertension, and we know that REM sleep may influence long-term glycemic control. So our patients that are taking their CPAP off reliably halfway in the night are not being well treated during some of the most critical time that they're sleeping. So for these patients, I would consider oral appliance therapy. And that's a summary I'm going to skip. The big thing I'd like you all to consider, and I think this speaks to this case, is combination therapy. And I think this is turning into a more normal thought process. This patient that Dr. Collop brought up does have severe desaturations, but at the same time, their CPAP pressure, I believe it was 7. And there's some small body of research showing that patients with a very high pressure have a low chance of being successful with oral appliance therapy, but this person already has a low pressure. If we combine a pressure, the patient had some residual obstructive sleep apnea, and if we combine an oral appliance with the patient, it's found that these patients, we can make them even more reliably compliant with the device and with the oral appliance together. and we can lower their apnea-hypopnea index and have a more thoroughly treated patient thinking about that. Adjunctive therapy should be thought of in lots of ways. Combining CPAP and oral appliance therapy is becoming more and more common in my practice. Oral appliances are used after suboptimal success with upper airway surgeries. After a patient has had bariatric surgery, it's put them in a milder range, which oral appliance therapy is much more successful with. And positional therapy is something that can be added to oral appliances to bring them into a successful range. And of course, for all of our disease processes we're thinking more and more of exercise. So thank you, and I'm going to introduce you to Graeme. Thank you.
Hi, I'm Graeme Mulholland. I'm current sleep medicine fellow at Emory, one of the 3 fellows, but I've done my training in ENT surgery, so I'm going to talk to you a little bit about surgical treatment options. So surgery can be thought of kind of in a few different ways, but here we'll think about it as an adjunctive treatment, so treatment primarily for nasal obstruction to help improve compliance to CPAP and improve use by relieving the nasal obstruction. Then secondarily, it could be considered as a primary treatment in that to obviate the need for CPAP itself. I've broken up potentially curative treatment options into 4 categories, the first being bypassing the obstruction. So this takes a form usually of a tracheostomy, which bypasses the upper airway by inserting directly into the trachea. It's very effective treatment, but is a low overall acceptance by patients. The second realm of treatment is probably what people are more familiar with, and this is the typical soft tissue surgery, so in the form of the UPPP procedure, which aims to address redundancies in the soft palate, as well as enlarged tonsils, and potentially at other causes of obstruction, such as enlarged lingual tonsils, which can be resected, or an enlarged base of a tongue, which again can be managed surgically. I'm going to spend the remainder of my time discussing 2 more prominent treatment entities in the form of skeletal surgery, which is represented usually by mandibulomaxillary advancement, which is a relatively invasive means of treatment but is the most effective. And finally, one of the new and developing treatment options, which is nerve stimulation in the form of hypoglossal nerve stimulation. So one thing I failed to mention, which was on my initial slide, is the importance of patient selection. And this is extremely important in selecting a patient that is likely to succeed with surgery as primary treatment option. And so we start with our physical exam. We look at the body habitus, so their BMI, as well as their neck circumference, as these can be good predictors. Increased BMI correlates very strongly with ineffective surgical treatment. We also look for deficiencies, so maxillary and mandibular hypoplasia or retrognathia, as well as the tongue size in comparison to their skeletal structures, and just generally to try to get a sense of the contribution of the tongue. The palate, as you can see demonstrated by the Friedman score, which gives a representation of both the tongue size as well as the soft palate orientation and length, and finally, and of course, the tonsils. This patient had an elevated BMI. They were studied when they had a BMI of 24, but they actually presented with a BMI of 35, which is a significant increase and may direct us in terms of potential surgical therapeutic options. They also have an enlarged neck. So large neck, one that is kind of synonymous or increases the likelihood of sleep apnea is thought to be greater than 17 inches, and this gentleman has an enlarged neck of 18 inches. They are also described to have a very crowded pharyngeal airway with a high riding tongue base, small tonsils, and some micrognathia. Our next step is to evaluate the sleep study, because this again can provide useful information in determining the most appropriate treatment. We want to look at the severity of the sleep apnea in terms of AHI, because this will direct us from more invasive procedures to more minor procedures or less invasive procedures. But more important than this is the degree and the frequency of desaturations, because this correlates most strongly with cardiovascular outcomes. We also want to be sure about the type of respiratory events. So surgery does very little, if anything, for central events. And so we need to be sure that we're treating obstructive apneas and hypopneas with surgical treatment. Finally, we like to put this in context. So you would treat a patient that has mild sleep apnea, that is not tired or doesn't have daytime presenting symptoms, as someone with mild sleep apnea who is very tired. You treat them very differently. And we'd also like to put into context any sleep comorbidities such as insomnia or claustrophobia, because this could potentially limit adherence to some of the treatment options that we have to offer. And one final point, this is a new study that is just kind of in the process of being published in relation to success of treatment with hypoglossal nerve stimulation. We found that people who require low CPAP pressures, so CPAP pressures less than 8, have a much higher likelihood of success with treatment with hypoglossal nerve stimulation than those that have require high CPAP pressures. So from the sleep study, this gentleman was a lot more slender at the time he was studied. He had mild sleep apnea with an RDI of 12, but the concerning finding on this is his extent and level of desaturations, desaturating to as low as 64. He required a low CPAP pressure, and he is sleepy as indicated by the Epworth Sleepiness Scale. I'd like to draw attention to the hypnogram here, and so above on the top line, this is his oxygen level. And these two areas I'd like to draw your attention to. So these are desaturations, and then this represents his sleep staging. And so these kind of black boxes are his REM sleep. So notice that his most severe desaturations correlate with his REM sleep. This is another important consideration for surgery, because we know surgery is less effective for treating REM sleep apnea than someone who is not as dependent or severe in REM. So additional tools we have at our disposal are in-office exam with supine endoscopy, where we would lie the patient more in a flat position and perform maneuvers, a mandibular advancement, which could suggest the benefit of an oral appliance device or possibly the hypoglossal nerve stimulation, as well as tongue protrusion, again in a similar way of evaluation. And we also ask them to simulate snoring, which gives us an idea of the site of obstruction. One final tool that we have at our disposal is that of drug-induced sedation endoscopy, which uses intravenous anesthetic agents, most often propofol, to simulate stage 2 and 3 sleep. This isn't sleep, but it's thought to be representative and gives us a better idea and a better impression of where the patient is obstructing. We typically try to use this as a surgical roadmap. This is a video of a DICE exam. You're going to see a mandibular advancement, so you see the soft palate come down, the soft palate's at the bottom of the screen, and you see the airway open up. You'll shortly see in just a few seconds when it's relieved, and you'll see collapse of the soft palate as well as collapse of the tongue base, which is more representative of their sleep, just right here. So we see the soft palate's collapsed, and then the tongue base is more posterior as well. So I'll talk about two specific techniques in more detail. The reason I've chosen these, particularly the maxillomandibular advancement, is this is the most effective treatment that we have to offer from a surgical perspective. Historically, it was used in a stage fashion, so it was utilized in patients that had already failed soft tissue surgery, but it has up to a 90% success rate, and this is all comers based on meta-analysis that has been done looking at this procedure. It's been utilized for since the 1980s and was put into practice around the same time CPAP was developed. The important things to consider with this is a fairly invasive surgery, and there is a prolonged recovery of several months. And depending on the overall health status, they can have limited recovery of the sensation to their lips and chin. They can have problems with occlusion and problems with infection, as you can imagine, with manipulating the maxilla and the mandible. One final thing, as will should become apparent with this image. So this procedure actually performs a Lefort 1 maxillary osteotomy, where we disarticulate the maxilla from the skull and advance it up to 10 millimeters. And then concurrently, we perform bilateral sagittal split osteotomies, one on either side of the mandible, preserving the inferior alveolar nerve, and then reapproximating the mandible to maintain their occlusion. The average displacement of the maxillary mandibular complex is about 1 centimeter or 10 millimeters. So as you can imagine, this pulls both jaws forward, which will give a more prominent facial profile, but it also significantly opens the airway and is the reason for the success in treatment. One final therapy I'll discuss is that of the hypoglossal nerve stimulation. You see the IPG device pictured in the upper right. It's relatively small and takes a similar appearance to a cardiac pacemaker. And this is implanted in a chest incision in the upper right portion of the chest. This is, by comparison, a minimally invasive procedure, but has a strict selection criteria. So adults are eligible. They have to have between moderate and severe sleep apnea, with the upper limit being 65. And they also have to have a BMI less than 32 to be eligible for this procedure. This offers about a 70%, up to a 70% success in appropriately selected patients. And this is measured somewhat differently than what has been discussed earlier, but it is an improvement by more than 50% in their AHI number and to a value less than 20 events per hour. That same measure of success was used to define success for the Maxillomandibular Advancement. The surgery is performed through 3 incisions, one underneath the mandible in the submental area. That's where a cuff is placed around the hypoglossal nerve to provide electrical stimulation to the hypoglossal nerve. A second incision, as I mentioned, is placed in the upper chest wall for the IPG device. And a third and final incision is placed in the lateral chest wall, where a respiratory sensing lead is placed between the external and internal intercostal muscles to sense respiration. Respiration is sensed, and a electrical stimulation is provided to the hypoglossal nerve. The crux of this surgery is to delineate where the hypoglossal nerve provides innervation to the retrusor branches, so the branches that supply muscles that pull the tongue back, to the ones that protrude the tongue. And you have to capture and selectively stimulate the protrusor branches so that the tongue goes out rather than goes back in. And then on the right, you see a picture of the remote, which a patient will use before bedtime to turn on the device, allowing themselves approximately 30 minutes to fall asleep. And then the final video that I have here is of active stimulation. Oh, yeah. I'm going to just turn the sound down here. It'll be a little bit distracting. So you see, prior to stimulation here, the patient is taking a breath. The respiratory lead is sensing respiration and then sending a signal to the hypoglossal nerve, causing a protrusion of the tongue, but you also see that the soft palate comes down as well. So this therapy is timed with respiration, and for someone that is not having central events, it can be very effective in managing their sleep apnea. Thank you.
If I get my panel to come back up here for a second, I'm just going to ask them what they're going to do with our patient now. So, Dr. Schulman, I think you already said, but let's see, what do you think we should do next with ES?
Well, the ES needs a coach, right? By his own admission, he's been lost to follow-up, and he's now coming back in. I tell my patients I'm a bit of a bulldog. It probably doesn't surprise anybody who knows me, and I will work with them as long as they want to. I won't force them to do anything they don't want to do. But this is an opportunity we have to help him be better. I think all of our panel agrees that CPAP probably, if the patient is adherent, is the best therapy. He's already got it in hand. I can make some tweaks to the device, get him a new mask, and hopefully get him happy. So I think it's a no-brainer before looking at these alternatives, which are both reasonable, to keep doing what we're doing with some better coaching. You know, firing the old coaching staff and bringing a new coach on board is a thing that football teams do. It's reasonable for patients to do it too.
Sheri, you think he's a candidate for a dental appliance?
chances of him doing real well with just an oral appliance is small. It's not unheard of. And I certainly would encourage him to follow through and give his all to CPAP. But I would add an oral appliance if he wasn't doing well, because it's a very conservative thing to do. And we've got a good track record of solving a lot of the stumbling blocks that keep people from using their CPAP and bringing them into a good range of success.
Graeme, I know you haven't seen him yet, but your thoughts about surgery for someone like this?
So I think it is a potential option. I mean, I agree. CPAP most likely, if we can optimize it, and possibility of oral appliance, I think those would be the first two lines that we should try in a gentleman like this. I do think, given his kind of persistent snoring and his significant weight gain, there may be some benefit of restudying him. If he is ultimately not able to tolerate either of the other two options, he may be a reasonable candidate for the hypoglossal nerve stimulation.
Okay, thanks. Yeah, I think what David and I talked about, we probably wouldn't restudy him right now if he's just going to get CPAP, but if he's going to get an alternative, it might be nice to get a new baseline for him. So that's all we have. Thank you.
A few minutes for questions.
Yeah.
Thank you very much for this very stimulating talk, and I really appreciate the fact that it's interdisciplinary, because as a primary care internist, I'm often faced with patients who've had one approach or another from different people, so it's nice to have a sense of all of them. Also, as a general internist, I am surprised at the prevalence data shown, because I feel like I have my antenna up pretty well, and I ask a lot of patients review of systems questions about sleepiness, but I'm detecting nowhere near the prevalence numbers that you showed earlier. So I guess my question is it a subset of these patients for whom it's important to catch them? And is there something I ought to be doing in all patients who have diabetes, heart failure, history of AFib, and other things in order to identify the people I'm missing to have evaluated?
Yeah, well, I'll give you my opinion on that. I think, as I said, I think the most critical group are the middle age, like 30 to 55 or 60.
30 middle-aged.
Yeah, okay. It's all relative. That seem to be at highest risk for cardiac and cerebrovascular disorders. I think we use this AHI of 15 as being the risk, and it looks like, the AHI is the prevalence data you get that you see is AHI based and may not necessarily be symptom based. And so I think, symptoms might, we talk about sleepiness a lot, but I think there's a lot of insomnia, there's a lot of depression, there's a lot of sleep disruption that may not get asked or may not get picked up. That is not necessarily a sleepy patient, because everybody's always thinking about sleepy, but we see a lot of people who have other symptoms that don't get picked up. And I think the other thing I would just say about the sleepiness is I think there's a lot of people who don't think they're sleepy, but they really are sleepy.
So because there's not a good rule-out test, are you prepared to handle the volume of referrals that this implies I should be sending you?
Yeah, well, we'll work on that. David, do you ever have
Well, I would advocate that. You've ordered, but it's not unheard of for non-sleep specialists to start with a home sleep apnea test. I think that's a very reasonable thing to do. The sensitivity is reasonably good for moderate to severe disease, not perfect, and then have them see us thereafter. I think that's probably the easiest place to start. I think there's some more subtlety to the cases. If you're concerned about other sleep disorders, central apnea, a referral first would make sense, in my opinion.
Couple off-site questions. One of which comes from Grady, asking about the oral appliances. How costly are they, and are they typically covered by Medicare, Medicaid?
They do have they are covered, but minimally. Medicaid does not cover them, and general insurance does.
What's the expense for that? What can a patient expect to spend out of pocket?
Out of pocket, about $2,500, and it should cover the first 3 months. But they don't have supplies to buy routinely either, and the devices last between 3 and 5 years, and sometimes longer.
Thank you. I got one more coming from Midtown. Does anyone foresee any further clinical benefit beyond systolic blood pressure lowering being attributed to CPAP use? And as a follow-up, is there any thought that folks with OSA and hypertension should take one or more of their blood pressure medications in the evening due to loss of nocturnal dipping?
So the question, I'll take the second one first. The blood pressure question is interesting. The studies that have looked at the association of sleep apnea and hypertension suggest that, of course, there's a very high prevalence, but that using a CPAP machine is about the equivalent of one antihypertensive medication, roughly. But as far as controlling blood pressure, antihypertensive medications are better than CPAP, hands down. I mean, all the studies that have looked at that. The timing of which doesn't seem that important. There's a couple studies that have looked at that. It's probably not as important as to when they take it as to whether they use their CPAP or not. Anything to add to that?
Yeah. What about other outcomes? I think are there other outcomes that can be mitigated other than hypertension with the use of CPAP?
Well, that's a little bit controversial. All the studies that have looked at outcomes, cardiovascular outcomes using CPAP, have not been particularly compelling. That CPAP can mitigate bad cardiovascular outcomes. The problem always is that what a lot of the panelists mentioned is that getting people to use their CPAP all night, every night is always a problem with the CPAP studies, because most patients, they'll use this 4-hour thing. Well, if they used it 8 hours and got through that REM period, would it have been a better outcome? And we just don't have studies that have been able to do that. Anything there?
Yeah, I mean, I think the issue is per protocol analyses, you can detect benefits in terms of atrial fibrillation risk. Right, and in recurrent stroke, I think maybe not primary prevention, but secondary prevention, there's some data. The issue is adherence, and so in intention to treat analyses, it's often hard to detect these differences because there are a significant number of non-adherers.
But the more they use it, the more likely they are to benefit.
I try to look in everybody's airway as a primary care internist like Dr. Spell. How good a screening test is a 3 or 4 airway score?
So, are you making reference to the Friedman or the Mulholland-Patty? I think in context, it can kind of increase your index of suspicion. We use it, from the surgical perspective, we use it to determine likelihood of success. So, in terms of, for example, people with big tonsils who are skinny do well with tonsillectomy for treatment, up to 80% success. People with kind of a worse Mulholland-Patty score have a tendency to not do as well with surgery. And same thing goes for increased BMI.
So the positive predictive value of it from predicting sleep apnea is modest at best, it sounds like.
Yes.
Yeah. I think we're at time. One last question, apparently.
So your guy was able to display REM sleep despite having oxygen desaturation. How can you talk about that? About how common is that someone is having this pretty significant oxygen desaturation but is still able to go through REM sleep?
Yeah, we see it all the time. They keep rocking through sleep. They often won't have deep sleep, which the bad apneics won't get deep sleep, but the REM pressure is so high, I think, that they get to REM. And unfortunately, that's a bad thing, because once they get to REM, they tend to have longer and way more severe desats in REM. But yeah, they do tend to. Most of our patients will get into REM sleep, even if they have bad apnea. Thank you.
Thanks, Ian. Thank you, Dr. Bell.
Thank you.
Survived another round.
That was very good. I figured it out after you too.